So let's start with introduction. Cancer cases are increasing globally, especially in the lower to middle income countries. So in Southeast Asia, we can see that there's a projection that the cancer cases will double by the year of 2030. At the same time, cancer survivors are also living with many other health conditions such as heart diseases and diabetes mellitus. So they are affected by these comorbidities due to aging because with the advancement of the cancer management, they are now living longer. At the same time, due to their lifestyle factors and some of the long-term cancer treatment effects. So living with all these health conditions are actually affecting their cancer management. However, in the current scenario is most of the clinicians are focusing on the cancer management rather than their comorbidity management. So there are many methods available to measure comorbidities. There are more than 21 methods available, and there are no gold standards established. So the more commonly used is Charlson Comorbidity Index, which is developed in the 80s. It is a scoring system for 19 predefined conditions. As we can see, for example, a patient with a heart attack, previous heart attack get 1 mark, diabetes get 1 mark, and many etc. So because the score is developed in association with poor survival outcome, those which do not have a poor survival outcome like hypertension and dyslipidemia do not fall in the group, therefore they do not have a point. This score is very easy to use, however it has some limitation because it may overestimate some of the risks. For example, in HIV, it has 6 marks in this scoring system. However, over the years, there is an improvement in the management of HIV, and hence this risk may be high for this population. In contrast, latent class analysis is another type of method measuring comorbidities. It is a statistical model-based system used to classify the patients into a different hidden groups or subtypes. For example, in our case, we group all the comorbidities and then we see which are the combinations of the patients that actually has a similar characteristic. This also used in diagnostic researchers. For example, in skin diseases, they are actually grouping the patients according to their symptoms and then to see which are the symptoms. For example, is it like inflammatory or is it infectious? So this comes to my study objective. The first objective is just to determine the prevalence of comorbidities in cancer. Next, to assess the comorbidity pattern in association with the treatment decision. And lastly, to assess the comorbidity patterns association with functional status. Next, move on to methodology. A cross-sectional analysis was conducted on the data gathered from the 3 Malaysian cancer cohorts. So all these cohorts are actually used to assess the patient-centered outcome and also the supportive care needs. So adults aged 18 years and above with confirmed cancer diagnosis with available medical records were recruited, and the cohorts actually span across public, academic, and private hospitals across various states in Malaysia. Some of the data sources are a mix of self-reports and medical records. For example, for social demographic data, it is from self-reports, and clinical characteristic treatment ECOG performance status is actually from medical record. Lastly, the comorbidity is mainly self-report and be verified with the medical records. So in case that there is a discrepancy between the two, we will take the medical records. So after we code the comorbidities according to ICD-10, then we will put it into a latent class analysis model, and we see which of these patients are actually grouped under the same similar characteristic. The LCA model was done for 2 to 6 classes, and we found that the 3 classes give a balance between the simplicity and also the clinical meaningful. And subsequently, how do we label these 3 groups is by comparing the commonly seen diseases in the group with the expected expected outcome for the disease. Then at the same time, because we want to make a comparison with the Charlson Comorbidity Index, a modified Charlson Comorbidity Index is also calculated, where we included 19 conditions, but we excluded cancer. So after we calculate the score, we also divide it into 3 groups, where the low Charlson Comorbidity Index are those with a score of 0, moderate is from 1 to 2, and high is 3 and above. So we run a statistical analysis. Multiple imputation was used to address the missing data, and then in order to assess the association between the comorbidity with treatment, comorbidity with functional status, a multivariable logistic regression was conducted. So here comes to result. In this cohort, 62.2% of the cancer survivors have one or more comorbidity. So by using latent class analysis, we identified 3 distinct classes. Class 1, as we can see from this bar chart here, are those with low comorbidity. They do not have any excess prevalence of the diseases. Next, class 2 cardiometabolic group. This group has a high prevalence of hypertension, obesity, dyslipidemia, diabetes, and also chronic diseases, chronic kidney diseases. So in this group, they have a high comorbidity burden, where they have a mix of cardiometabolic class from 2 to 5 cardiometabolic diseases. Lastly are those with multi-system comorbidity. All of them in this group have 4 or more comorbidities from various organ systems. This is a busy slide showing that the social demographic characteristic by according to 3 groups. There is a statistically significant difference in terms of age, gender, ethnicity, education, income, and also center for treatment. So same goes with the clinical characteristic. The cancer type, current cancer status, cancer staging, and eco-functional score are different. So in order to make life easier, I've made this infographic. As we can see from here, those low comorbidity group are younger. Their median age is 51. They have a higher education level, which they have a higher percentage of them getting a tertiary education. They also have better ECOG functional score, with a higher number of them in having early stage cancer. Cardiometabolic group, interestingly, is the oldest. They have their median age is 62. They have a low education level, and the private hospital usage for this group is actually the lowest. Most of them receive their treatment in the government hospital. Lastly, for multi-system comorbidity group, they are older with a median age of 55. They also have a high education level. However, their ECOG score is poor, and also they have the highest number of them with recurrent cancer. So this forest plot shows that the adjusted odds ratio of cancer treatment across the comorbidity class. So odds ratio of 1 meaning that there's no difference between the treatment that we want to see compared to the reference group. Odds ratio of more than 1 means that there is a higher odds of receiving that treatment compared to the reference group. And vice versa, for those odds ratio which is less than 1 means that the treatment that we want to investigate has a lower odds when we compare to the reference group. So what's the reference group here? Reference group here are those with low comorbidity group. So when we look at the red color box, we can see that compared to the low comorbidity group, those under the multi-system group have significantly lower odds of receiving radiotherapy, chemotherapy, and anti-HER2 targeted therapy. However, there are higher odds of receiving immunotherapy. At the same time, there's no significant differences in the receipt of surgery, CDK4/6 inhibitor, or hormone therapy. We run the same analysis using Charlson Comorbidity Index, and as you can see from here, despite that the high CCI score carries the high comorbidity burden, it is only found to be associated with a reduce of chemotherapy use and increased immunotherapy use, but not with other treatment. In the association for comorbidity with functional status, regardless of which of the method that we use, we also found that the patient with the high comorbidity burden is associated with a poor functional status. So this, let us summarize for objective 2 and 3. So in terms of comorbidity with treatment and comorbidity with functional status, we found that those with low comorbidity and cardiometabolic has a good treatment access and good functional status. So despite that this group is having 2 to 5 different types of comorbidity, they are still getting a very good treatment. Then from the multi-system group, we see that there is a lower receipt of chemotherapy, radiotherapy, and also anti-HER2 therapy. But interestingly, they are receiving a higher number of them are receiving more immunotherapy, and they have a poor ECOG functional status. So we run the sensitivity analysis to compare the 2 models. In the summary, the latent class analysis outperformed the Charlson Comorbidity Index in predicting surgery, chemo, and also radiotherapy. There is a similar performance for immunotherapy, hormone therapy, and also CDK4/6 inhibitor. For ECOG prediction is comparable for both, and there is no multi-collinearity detected. next goes to discussion. So why some of the possible questions that come into mind is why this group actually receive less treatment, because the cardiometabolic group, as we understand, they also have a very high comorbidity burden. But the multi-system group, they are also under the high comorbidity burden, but only this group receive less treatment. So as the name implies, those with multi-system comorbidity groups are those having multiple chronic conditions affecting different organ systems. So there's a higher risk of treatment-related complication. Then at the same time, due to their poorer functional status, they are also less fit for intensive therapy. So in this case, the multi-system group, we found that we thought it will be across the board. All of the treatment will be the same, lower odds of receiving. But interestingly, we found that immunotherapy has a higher percentage of using in this group of the patient. So some of the possible explanation is they are having a different type of side effect profiles. And then they are also considered to be better tolerated than chemotherapy in terms of the side effects. Not to say that immunotherapy has no side effect, but their side effects are different from the chemotherapy, because chemotherapy, as we know, is more profound. It can cause a reduced white cell count, it can cause severe nausea and vomiting. So next, for cardiometabolic group, when we compare, this group has a higher prevalence of diabetes, hypertension, dyslipidemia, chronic kidney disease, and obesity. So they receive treatment at a rate similar to the low comorbidity group, despite that they are also having a high comorbidity burden. So what makes this group different is the standard cancer treatment is still very visible, but they are having a higher risk of treatment-related cardiovascular toxicity. So at the same time, it will requires us for close cardiac monitoring. And one key challenges is after the patients are diagnosed with cancer, they are usually forego all of their chronic medications and only focus on cancer management. So this will also increase their risk of getting further cardiovascular disease. So let's summarize these two methods is the latent class analysis provides a refined risk stratification. Although both of the methods can identify those with a high comorbidity burden, only the latent class analysis is data-driven, and it can go a step further by identifying which of the patients which is associated with poorer treatment outcome and poorer receipt of the treatment. Despite Charlson Comorbidity Index is simple to calculate and it only requires predefined weights, and there are many available calculator online, it cannot identify high-risk groups, and luckily both of these are regression compatible, so we can do further analysis to check for their survival and also the other treatment outcomes. So what are the possible clinical use after we have calculated all this with latent class analysis with Charlson Comorbidity Index? Some of the possible clinical application is including informing multidisciplinary team discussion. If we found that in our clinic or in our setting there is a group of patients with multi-system comorbidity, and then they are mostly with recurrent cancers, and at the later stage of the cancer, probably we can initiate early palliative care referral. For those with the cardiometabolic classes, we can have early cardiology referral, or we can also translate this model into an EMR-based algorithm to classify the patient automatically at the diagnosis of the first visit. Because this is quite easy to use, because we just need categorical data or binary data like yes, no, yes, no, yes, no. When we answer, we just click, and then the system will actually show us the patient's grouping. So lastly, if all these are not available, we can develop a short checklist that maps the patient onto the latent class analysis without the full modeling, making it more easy to use in routine clinical practice. So these are all my references. With this, thank you very much.